Good morning, everyone. I want to first of all thank everyone for the energy, enthusiasm, and the commitment to working with people who have substance use disorders and who are living with or at risk for HIV. There's a number of agencies who are here. It's wonderful to see young people in the room. This is great. Awesome. Thank you for being here. We have a lot to talk about today. We haven't done this in a long time, and I want to start first by reminding folks that this is a community effort. We're seeing a lot of really unsettling things going on among the people we serve in all of the places where we meet them. There's several reasons for this. One is our culture continues to become more and more coarse. There's also fewer and fewer people who have access to housing and regular food. We see this at our clinic in Hollywood, and in the past year, it's been incredibly much worse than it was at any time since I've been working in the field. These are times where we as a community have to join shoulders and arms and pull together the network to be able to help these folks, because so many of our folks have no credit anywhere in our society. So this is really hard. I know one of the things, I work with the center folks, and one of the things that we've been talking about is just how much we have to take from people because they are so discriminated against. They have violent experiences on the street. They may be substance involved and get stigma from that. You can't call 911 for help if you're a substance user and overdose. There's lots of issues here that we as frontline providers take from those folks, and we have to do something with that energy. So one of the things I hope that will come out of today is a spirit of community that will continue from this, that we look after each other, that we actually provide support to each other, because the work we're doing is not only important, but it's also corrosive. It will eat at us. We need to be able to share our stories, to be able to hold each other and say, I'm here for you. This is what we're here to do today. So in that spirit, I want to bring us together to think about this as a day of not only seeing facts, but hearing stories, experiences, some ideas, and to begin thinking about, as a community, how do we begin to address this issue of methamphetamine that continues. It's not new, this is continuing. And in fact, as some of the folks I've been talking with, this is like it was back in 1992 and 94, particularly in the gay community when methamphetamine was really at its highest. So I'm hearing things, I'm seeing things that really takes me back, and that's not good. So I want to thank a lot of, today is because of a lot of people. First off, I want to thank Wynn Cow. She organized this. Wynn is a treasure in my life, and she's a treasure in our community as well. So I certainly have a great deal of love and respect for all the work that she does. I also want to thank Terry Smith from APLA Wellness. It was at World AIDS Day last year where Terry actually brought up the issue of addressing straight on the issue of methamphetamine in our communities. And that impulse is actually leading us to today. Some folks who've been working in the field for a long time, Cathy Reback at Friends Research. The City of Los Angeles AIDS Coordinator's Office, Ricky Rosales. Cheryl Barrett from the Commission on HIV. Our DHSP colleagues. Mario Perez flew in especially to be here today. I want to thank Mario for actually coming today. And your great team with Kyle Baker, Wendy Garland, I saw you, and Michael Green. You guys have been real warriors in this effort, and I really appreciate you for signing up for another round. So here we go. Tom Donahoe and Sandra Cuevas from the LAPA ETC is providing CEUs for this event. So if you need CEUs, we want to thank Tom and his group. Craig Vincent Jones So you've always been a supporter in providing feedback and keeping this methamphetamine issue in our vision. And the support team, Izzy Chu, Dami Jolayemi, Dahlia Ferlito, and Susan Forrest. Thank you all for this. And I just want to thank everyone for being here. So I also want to close my thank yous by just recognizing two very important people who are at UCLA, who are leading the policy effort to address the issues of methamphetamine and HIV in California, Ian Holloway and Ekow Sey. Ian is going to talk with us this morning and welcome us. He is an associate professor at UCLA in the Department of Social Work at UCLA, and he has a policy center funded by CHRP to look at aspects of HIV and substance-related issues and other related issues to HIV. Ian is actually leading the field and the effort in terms of helping us to work not only with dominant culture, but with people who come from multiple underrepresented groups who have problems that relate to living with HIV, being at risk for HIV, and having addiction and addiction-related problems. So without further ado, Dr. Holloway.
Thank you, Steve. So I'd like to add my welcome. I know some of you, but for those of you who I haven't had the pleasure of meeting, I'm Ian Holloway. I'm the academic principal investigator of the Southern California HIV/AIDS Policy Research Center, as Steve said, and this is an academic community collaboration between UCLA, APLA Health, and the LA LGBT Center. So we're really pleased to co-sponsor this event with CHIPS. Meth and other substance use impacts many of the communities that we work to serve. And we want to extend thanks to our funder, the California HIV/AIDS Research Program. With their support, we've been able to lend our hand to efforts like today's conference. Our mission is to ensure that you, along with policymakers throughout the state, have the most accurate and up-to-date research to help inform your decision-making on the ground and at the policy level. So you may recall last year when the California legislature passed Assembly Bill 186, this bill would have authorized the city and county of San Francisco to approve overdose prevention programs. And this would have established the state's first safer drug consumption sites. Unfortunately, that bill was vetoed by Governor Brown, and I just wanted to read you a bit of what he said in his veto letter. He closed by saying, "Enabling illegal and destructive drug use will never work. The community must have the authority and the laws to require compassionate but effective and mandatory treatment. AB 186 is all carrot and no stick." So our work as a policy research center has documented the effectiveness of harm reduction interventions for substance users, especially as it relates to HIV. I encourage you to check out our policy research briefs. We have a resource table there. Gregory is in the corner and can chat with you about some of our work. You can also find us online at chprc.org. To give you a little more context about the ongoing policy work for around these issues, this year California Assembly Member Eggman, and Senator Wiener are trying to pass legislation once again on safer consumption sites. So with AB 362, which is the bill that's currently coming out of committee, is signed into law by Governor Newsom, the city and county of San Francisco will offer a safe space where vital services can be delivered to substance users. This would include providing injection drug users with a hygienic space, supervised by healthcare professionals, where people can consume pre-obtained drugs while accessing sterile supplies. Most of all, such sites will give providers the ability to intervene and offer consumers facing high levels of stigma with access to referrals for substance use treatment, HIV services, and other programs. So on this issue, we've developed a short policy brief, and using this tool, our state's policy advocates are educating legislators about the evidence of such harm reduction programs. If you have questions about our work, please reach out to us. We'd very much like for you and your agencies to be part of our ongoing research efforts moving forward. So with that, I'm going to bring Steve Shoptaw back up. Most of you know Steve, but I'm going to give a little bio about some of the great work that he's doing. So Steve is a licensed psychologist. He's the director of our Center for HIV Identification, Prevention, and Treatment Services, CHIPS. He's also a professor in the Departments of Family Medicine and Psychiatry and Biobehavioral Sciences, and he's vice chair of the Family Medicine Department at UCLA. Steve is the clinical leader for several HBTN studies, including HBTN 061, which documented that high-risk Black men who have sex with men have 7% HIV incidence in Los Angeles. He's doing really incredible work in diverse communities throughout Los Angeles. And so he's going to speak today on what the landscape looks like around HIV and meth in LA. Welcome.
Thanks, Ian. And it is an honor to be here. I just keep getting older, so. So I've been asked to speak, to set the stage for us to talk a little bit about what's happening with methamphetamine nationally and locally. We are in for a treat today. I'm going to leave time to take questions and have a little bit of dialogue after my talk, because I can get really teachy. I don't want to do that today. But I do want us to leave the room with a sense of urgency that we really have to do something, and we really have to do something now. So I also want to start by acknowledging my funders, and also one of my very good mentors in life is Ferd Egan. Those of you who probably don't remember Ferd, he was a cranky old man with AIDS, as that's how he described himself. And he was willing and bold to try different things. Like, Ian, you were just talking about the idea of harm reduction as a way of improving the lives of people, as opposed to thinking about it as enabling people to do bad behavior. So, you know, I want us to be bold in our thinking and to continue the spirit of Ferd as we kind of think about the work to move forward. One of the things he did is, this is a landmark study. It's available online. Dr. Reback wrote it. And it's certainly something that is as relevant today, unfortunately, among gay men as it was when you published it originally in 1996. It truly is a remarkable, remarkable report. It's on the website for Cathy's Friends Community Center, and you can download it for free. It's great reading. So we're going to talk a little bit about epidemiology, less about biological links, some behavioral interventions. We're going to close with some policy and some considerations. And one of the things I want to start with is by pointing out that among men who have sex with men, methamphetamine is a high-risk behavior because it engages a lot of opportunity for either transmitting HIV, because if you're taking methamphetamine and you're a MSM, you're unlikely to remember to take your medication regularly, so you might have blips of viremia. And during those periods when you're high and having sex, you could be moving virus forward. We know that this corresponds often with syphilis and other STD infections and outbreaks. So that sort of happens. It is for HIV negative guys, it's a risk for becoming HIV infected. Cathy's going to talk a lot about that today. But you know, rather than talk about all the horror that comes from these sorts of behaviors, it's always really important to remember that methamphetamine has an amazingly pleasant effect on the brain. So it is a good thing. It is a really wonderful thing to have methamphetamine on board in terms of your own personal pleasure. It's a nice thing. It confirms issues of identity, of being a gay man, of being a drug user, of having your HIV status be a certain way. It allows you to enhance sexual functioning. Sometimes things won't work the same way without meth that they do with meth. So it's just a completely different room that men can go through, sexually speaking. It boosts self-confidence. It improves productivity. It helps you lose weight, and it gives you strong body experiences. And for those who are approaching certain ages, it can help you feel a lot younger too. It brightens your mood, and it's really a boost for people who are aging and are living with AIDS. So it's really good to remember these positive things, because the people we're seeing aren't degenerates. There are real reasons for why they engage this drug use. It's not just that they're trying to be raging dope fiends, that this drug fits an important niche within people's lives. And as we work with them, it's important that we remember this. So in terms of the epidemiology, here's the bad news. Methamphetamine is hitting the East Coast. And if we look here at treatment admissions for opioid dependence across the country, we see almost a doubling over the past 6 years in terms of people who mention methamphetamine use when coming in for treatment for primarily opioids. Here we see, even in West Virginia, look here, you can see this is 2015 to 2017. Here's the fentanyl spike that we all see in all the charts. So that's going on there. But look, this is the hills of West Virginia, and look what's happening with methamphetamine. Methamphetamine is hitting the hills of West Virginia. It's in the Midwest. It's everywhere there is an ongoing opioid epidemic, methamphetamine is present. In LA County, Gary Tsai's group actually published this lovely tear sheet. It's available online, and my slide deck has it here. It was in March of this year he published this, showing a 475% increase in deaths related to methamphetamine, attributable methamphetamine, over the past 15 years. So a 4-time increase, going from 40 to over 170 deaths between 2000 and 2014. And if we just look here and we're watching the mapping of the opioid epidemic, you can see the deaths increasing here. There's strong representation of all race ethnicities, and as we expect, we see that like 3 times more likely to be to have an STD, particularly syphilis, than if you're not using methamphetamine when you come in for treatment. Looking at drug reports, drug seizures, we can see LA County leads the nation in terms of the amount of methamphetamine that moves through the Port of Los Angeles, largely. And we see nationally it's pretty high. These are mostly West Coast cities through here, but you can see here, this is Maine at 6%. And if we look at treatment, we start to see some blips starting here. These are significant increases across the East Coast. Again, publicly funded treatment slots for methamphetamine is tied or higher, depends upon the month you're looking at it in terms of funding for public funded treatment slots in LA County. Which raised some of my folks because of the East Coast non-involvement, some of my colleagues wrote this editorial, which you don't even need to read the paper, but the whole idea here is, if you can. So we're going to hear a little bit later about how methamphetamine use is linked with HIV incidence in MSM. One of the things that's very important to remind ourselves about, and Cathy's going to talk a little bit about this, is that statistic that Dr. Holloway talked about in terms of a 6 to 7% incidence rate among Black men who are having sex with men in Los Angeles. So I want us to kind of park that, okay? So that's an important, that number's about 5 to 6 years old. So it's not quite as high now as it was then because we have PrEP on board. But the idea here that we have a differential involvement of Black men who are having sex with men with HIV is something we'll be developing as a theme through this, and perhaps we might want to be thinking, in specific bins as we think about what we want to do. I want to talk a little bit about some data that we have here at UCLA with my colleague, Dr. Pamina Gorbach, and I. We run the Minim Study, which is a cohort study of younger, 18 to 45, men who have sex with men, primarily of diverse backgrounds. So most men are from about 40% each in Latino and African American MSM, and a mix of others in the other group. What we see here is, as of October, we had 10 seroconverters in the HIV negative group. It's now 11, and excepting one, all of them were around methamphetamine use. Okay. Our incidence rate is about 3%. We've had 8 deaths. And you can see here that, we built the cohort so that we enriched it with people who were substance using. And you can see here, this is, the orange is positive and the gray is negative. You can see negative guys are more likely to use marijuana, whereas positive guys are more likely to use meth. We also have seen in the cohort among both HIV positive and HIV negative men who have sex with men that methamphetamine use increases depression symptoms, which is a real hallmark. So methamphetamine itself brightens mood, but when you take methamphetamine away, it causes withdrawal symptoms. And those symptoms are pretty disabling, particularly in the setting of methamphetamine dependence. What happens is you have this like 85% June gloom day that lasts for 6 months or longer. And all it takes is one dose of methamphetamine and you're back up where you want to be. So that's called negative reinforcement. You have the drug that takes away those negative symptoms. So it's a really hard problem to treat. So we all know the stories of men and women who've tried for weeks or months on end to not use methamphetamine and just get sick and tired of feeling crappy in the brain. And then they just take their dose and off they go again for a lapse or relapse, coming back around again. But the depression, this mood disorder, dysregulation, continues to be high in these groups. And you can see here that in those who have no substance use, depression is low to begin with and drifts down over time, which is what we see in the cohort. Other substance use, it's a little bit higher, but it's significantly lower than the meth users. And it also has a negative slope. So methamphetamine and its recovery seems to have some really horrible things that happen to your mood. In terms of thinking about, well, one of the questions we also want to talk about is, so what should we be recommending for our patients who have, or our participants who have methamphetamine use? Should we demand that they try to become 100% meth abstinent? Or is there some advantage to being partially abstinent or less in methamphetamine involved? So we asked this question from our data in the M study, and what we saw here was that we saw a stepwise ordered relationship between the frequency of dosing of methamphetamine in the past 6 months, of weekly or more often, less than monthly, or none. And we saw a significant predicted relationship between the likelihood of being unemployed, having unstable housing, ever been in jail, being a cigarette smoker, using heroin, using poppers, having concurrent partners, and look at this syphilis positive as well. So in all of these settings, the amount of methamphetamine you're using is actually a predictor of really bad things. And there's a benefit to your health to use less meth. So one take home today from my data is going to be that rather than set a all or nothing sort of bar, we need to be thinking about leaving space for people to reduce their level of methamphetamine use as a positive health behavior. Rather than branding people as treatment failures, begin to think about ways in which they're improving their health by continuing to try to address this methamphetamine problem. One of the places that I'll point out here where we don't see sort of a difference is HIV positivity. Fully 2/3 of men who have sex with men, HIV negative or positive, are likely to have HIV if they're using meth. Okay, so it's really this thing that Cathy's going to talk about, this time to event sort of thing. If you're HIV negative men, you saw the number of incidents continues to tick up if you're using meth, and that's what we see. So in terms of behavior, what can we do about it? There's some behavior change tools. Our group here locally in Los Angeles, we've been leading the field in terms of what to do. One of the best things we have is this Getting Off manual. It also is available online at Cathy's Friends Community Center. It has the manual is there. It's a cognitive behavioral tailored cultural approach to treating gay men who have methamphetamine use. And we tested what would happen if you included contingency management with it back in the early 2000s, affectionately called peeing for dollars. So we believe in using incentives. If we see the desired behavior, we should use an incentive. We were able to show that any condition, cognitive behavioral therapy, the Getting Off specific manual, the contingency management alone, just providing the contingency management, or the contingency management plus cognitive behavioral therapy, that during treatment, any condition that had the incentive significantly outperformed standard cognitive behavioral therapy for providing treatment, being methamphetamine abstinent. And that was for up to 4 months. We also saw, we were among the first to publish that if you stop using a lot of methamphetamine, you zero out basically a lot of high-risk sex. We use contingency management in a prevention setting. Cathy and Rafi Landovitz actually did this brilliant study to use contingency management with post-exposure prophylaxis, and was able to show that when you incentivized methamphetamine reduction using contingency management, you saw significant increases in the amount of people who completed PEP treatment and the amount of people who were PrEP adherent. Both relevant outcomes for controlling HIV infection, which is very exciting. For people who are still using, there seems to be a significant effect of using prevention behaviors. Stephanie Strathby and Tom Patterson in San Diego did 2 programs, one for HIV positive men who have sex with men, and one for HIV negative heterosexual men and women, using a motivational interviewing approach, and was able to show that at 1 year follow-up, significant improvements in percent of protected sex were observed for these motivational interviewing approaches compared to a standard discussion and education group. There's opportunities to think about medications. Phil Coffin and Grant Colfax from San Francisco have published a small study showing that mirtazapine, the antidepressant Remeron, actually reduces the amount of methamphetamine that's used, and also reduces high-risk sex for gay men in San Francisco. This was a small study with 60 people, 30 in each group. What's coming is a replication study that shows exactly the same findings with 120 or 60 per group. So I've talked to Phil, and he's actually replicated this finding in MSM. So something to think about is if you're thinking about adding some sort of biomedical component to your work, is to think about adding mirtazapine. Some of the clinicians I've talked to, they raise questions about whether mirtazapine might cause weight gain, which is a concern among gay men. But apparently, many men take the drug and they reduce their meth use and they stop having serodiscordant unprotected sex. Another approach is MSM messages, SMS messages. Cathy Reback also has been doing some work with using prepackaged, culturally developed, relevant risk reduction methods. These are available for using with SMS text, and very cool. You can kind of spend some time in the social support model, health belief model, and social cognition models with different messages that are used through here. Very cute, and showing very nicely that for sex on meth in the past 30 days, those messages themselves, the orange bars here, actually produce more reduction in the times meth on sex in the past 30 days than having those messages plus a peer health educator or just assessment only. So something is happening here in terms of these messages and changing people's behavior. It's a low cost, low intensity intervention that produces some pretty significant change. So I want to end us so we can have a few minutes for questions, but the question is always, what is going to happen here if we don't do anything more or don't do anything differently? Moden Nosek at University of British Columbia took data from Los Angeles County Health Department and built a model, training the model with data from the publicly available data on 2012 to 2015, and asked what would happen to infection rates if we just continued the same level of intervention and things going on. And you can see that for the next 15 years or 15 years or so, that things are going to stay pretty much where they are. So that's a challenge to me. That's not acceptable, right? It's not acceptable to any of us to just continue to do the same thing and expect we're going to see something different. So that's the basis of having this meeting today, is to begin thinking about what do we need to pull off the table? What do we need to put more time into? Because what we know is that about last year about this time, 3 men, gay men, died because they used what they thought was cocaine, or we're not quite sure what happened, but there was fentanyl on board, and those guys fell over and died. So the question that as we've talked about this in rooms is, is that some guys who were looking for the fentanyl experience? Because there certainly is the case among drug users that some men and women want to see what it's like to use fentanyl. So that could be happening. Or is it something that's in the distribution network that we need to be careful about? Certainly, in New York, fentanyl has been targeted in the same way. And they've come up with some really clever sorts of, these are coasters that are at gay bars that, just kind of put the message out there, just reminding people about fentanyl. I know that there's a lot of fentanyl testing going on in different venues here in town. The center is doing it. We do an M study. There's folks who are doing it around town as well in treatment settings, which is great. And we're not seeing much uptick, but we're starting to see uptick. So we make this thing worse with meth by now thinking about fentanyl, and I will direct you to Sunday's New York Times article that had a very disturbing article about how fentanyl is not, or heroin is not even available anymore on the East Coast. That when you buy what you think is heroin, it is fentanyl, and there is just no more market. It's not about demand. It's about the market has made a decision. The deliverers have made a decision that the distribution networks, that it's easier to deal with fentanyl, and that's what's happening there. So this question about the potential for fentanyl infiltrating the methamphetamine stream is something we have to be careful about. So I want to leave us with some thoughts. The take home today and the discussions we're going to have is to get smart about our investments and monitoring our outcomes. We're doing great work. We are monitoring our outcomes. This is great. The county has really done a great job in getting us there. But we need to disaggregate investments and recognize that people who don't have these problems, who are living with HIV, don't need extra help. But we need to think about those investments and what we need to do with those who have additional challenge to HIV care and prevention, especially methamphetamine using MSM, and those men from different race ethnic groups. We need to ramp up simultaneous involvement of existing levels of public health, addiction, and primary care systems at current levels after the Medicaid expansion. What that means is we need integrated care with the ongoing sorts of degradation of our society, the coarsening of society, and the lack of resource, particularly among those who need it most. It's really a cost to go to here for this, to there for that, and over here for something else. It means taking time away from your productive hours, either doing work or doing things, and getting this. We've got to think more holistically about our participants and the people we're intervening with, and build our systems so that we can meet their needs. It may mean some coordination that may not be there right now, but that would be something great. And then we just need to recognize the unique status of methamphetamine in promoting HIV incidence in MSM. It is different among MSM. We need to pay attention to that. And as we did in 1996, we need to reorganize and come at this with some really good ideas. So I'll stop for questions.
I'll kick things off. Good morning, Mario Perez from THSP, and proud partner to Steve and the others that were mentioned. I really want to make sure, Steve, that we impress upon that last point. We have an HIV prevention portfolio, and we have released an LA County HIV strategy. For those of you who haven't seen it, if you go to LA-County.HIV, it'll come right up. And we have said that we need to get to 500, no more than 500 new infections by 2022. And we're at about 1850 now. You and I have had a lot of conversations about the concern around the syphilis epidemic, the rebounding of meth, the opiate usage, all the things that are challenging our ability to decrease the number of new infections. As you think about our current portfolio, what are the most glaring things that are absent? Because I think that this forum, we should walk out of here at 12:30 with a very clear set of 3 or 4 things that we should be doing in LA County to improve our response much more holistically. And as we think about drug user health, I'm glad that we're tying it to the HIV epidemic, but there's an ongoing Hep C concern, syphilis concern, a range of other issues. There's increased attention at the federal level. It's a little bit slower at the state level, but I think it's growing. So we need your best guidance and advice on if we were to change our portfolio, not in the next 15 years, but in the next 12 to 18 months, what does that look like? And I'll just mention one thing about the strategy. We said that for LA County to meet its goals, we need to have a number of things happen, including unprecedented transparency and accountability. But we also said we need political will, and we also said that our community of partners who are on board, if we say, let's change our portfolio in this area, everyone needs to be on board. And what we can afford is for community-based providers who are funded to say, don't touch my contracts. If they're not having the impact we want, as a community, as we started off by saying, we need to make those changes. So I'd love to hear either now or at 12:25, what are the things we need to add to our portfolio? Is it more CM PEP that Reback is doing? Please let us know.
So that's a great question, Mario. Thank you. So we have been thinking about that, and you and I have been having discussions. I think one of the things that is going to be most important to start this off is a recognition that we live in a region, not just LA County, that we have people who can't afford to have housing in LA County. They may work or play in LA County, but they live in Orange County, San Bernardino County, Riverside. So we need some coordination locally. We're half of the California cases of HIV, just the 4 counties, and we've never met once to talk about coordination. So I think that's one of the things that's high on my list, and I know it is on yours, and we need to make that happen independent of what the feds do with us. Number 2, as you've said, we need to get high-risk people on PrEP, and that means a lot of different things. And I'm not going to launch on that. But the other part is to get people who are HIV positive to virally suppressed, particularly in the substance users, the homeless folks, that sort of thing. So we need to the next set of thinking we need to do is organized around that specific group and to come up with a set of strategies. It may involve providing Cadillac addiction care for some of those folks, because the opportunities for infections moving forward are going to be high, and the cost for that Cadillac care is going to be less than paying for the new cases that are going to be transmitted. So, some thinking around that's we've been having these thoughts, and I think it's just time to kind of move now, because I can guarantee you 80% of the people who are living with HIV or at risk out there don't need any of that stuff. So let's let them live their lives. Let's go focus let's start to disaggregate this group who's maybe 15 or 20% of the folks that are out there who are at risk, and get smarter about what we want to do. So I like those ideas. Other questions? I want to continue this.
Good morning, my name is Misty, and this is my first time participating in an event like this, and I'm super excited. And I had no idea that there was such a strong format to prevent and to help people live with being positive and know that they can still have a healthy life. I would like to know, as being my first time, what I can do to participate. And I'm a little nervous or brave, I guess you'd say, because I really, I've been a meth user for over 32 years. And I'm negative. However, it can affect everybody. And I just want to participate.
That's awesome. So join us. See me at the break, and we'll hook up. Also, Misty's sitting right over there. So agencies who are looking for this sort of energy, there's Misty right there. Okay. All right. I'm going to have to close this off. I want to keep us on time and bring us to the next presenter. Our next presenter is Dr. Cathy Reback, who is my very good friend in life. I don't want to go down memory lane too much, but we were among the first who actually recognized that men who are having sex with men who are using methamphetamine have particular risk for HIV infection. And it was those initial early horrifying days of seeing 60% of men who are having sex with men who are using methamphetamine having HIV. And that was at a time when we didn't have highly active antiretroviral therapies. And there was discussions in rooms about, do these guys merit whatever treatment we have available for HIV, given that they're out there using these drugs. So thank God we're not at that discussion right now, and we will work hard to make sure we never get back there again. But Cathy is a colleague of mine and a friend. She's a senior research scientist with Friends Research Institute, a research sociologist at Integrated Substance Abuse Programs. Actually, she's a research scientist at the Family Medicine Department now. She's the director of the Combination Prevention Corps for CHIPS. She's the founder and executive director of Friends Community Center, and for over 20 years has been delivering some of the most vital and community-based transgender, gay, lesbian, bisexual, street-based services. She's really been at the center of the HIV epidemic and the addiction intersection, and has a lot to talk to us today about what we can be doing as we think about seeing where we are today and where we need to get to. Cathy.
When I started doing this work in 1994, I never thought I would still be doing this work in 2019. So it's wonderful to see all of these people here and how many people are so interested. And we invite new people to come along and get involved. But I have to say, on a personal level, there's a part of me that's disheartened that I have been doing this work for 25 years and I'm still doing it. I had hoped to have aged out and retired by this point, but Steve, I guess you and I were here for the long run. I want to acknowledge Steve. He and I have worked very closely together for the past 25 years. We've raised our kids together. I also want to recognize my other collaborators, Dr. Grella and Dr. Fletcher, and the outreach workers who do the field, who are out on the streets every day. There's a few of them here from Friends today. I thank you guys for your hard work. When you're out there, when you're out there talking to guys and it's cold and it's raining and you're wondering why you're there when you could be at home, streaming a TV series, you're going to see a little bit about the fruits of your labor here today. So thank you. The participants who take the time to talk to these guys on the street, these people, they're just out on the streets trying to, pick up somebody or get high, and somebody comes up and starts talking to them and they take the time to have a discussion. I also want to thank, really from the bottom of my heart, Mario Perez has been funding this work for decades, and also the City of West Hollywood. We have Mario here and representatives from the City of West Hollywood. It might seem like a minor effort to fund street-based work in a time when there's biomedical interventions and a lot of other complex work that's being done, but we don't know what's going on in our communities without having people on the front line. So thank you, Mario and the City of West Hollywood. So basically, okay, so if you tap after every slide, I am not going to you're going to waste my 15 minutes. So let's just get through this all together as a team. Wen back there is going to shake me off of here in a few minutes. So meth and HIV go together with MSM. We've known this for 25 years and I'm still saying it. Methamphetamine use is commonly used by MSM in conjunction with sex for all the reasons that Steve talked about in his slide, all these strong associations with sexual risk behaviors, and then there's this association of HIV prevalence, triples HIV incidence, and HIV positive meth users have lower rates of viral suppression. So this is some work that Steve and I did quite a while ago. I'm going to show the references at the end of the presentation, that we look at how people use meth and its relationship to their HIV prevalence rate, these recreational users who just use occasionally, but at least once a month tend to have a 23% positivity rate. Chronic users who are using on a regular basis, 42% HIV positivity rate. Those that enter outpatient treatment, 61% positivity rate, and those that are in residential. And why is there a distinction here between outpatient and residential? Because when the use progresses, it gets to the point that these guys will not have successful treatment experience through intensive outpatient, and they need to go into a residential facility. And also, simultaneously, the rate of HIV infection increases among these users. So then when you add the implications for interventions between, all these guys, you want to have HIV prevention interventions at all of these levels. And of course, the type of HIV prevention interventions you're going to have differs based on the level of use. And then meth treatment for folks at this level. So when we look at substance use disorders, specifically with methamphetamine use, Steve talked about all of the good things that happen when you use meth. It's a lot of fun, right? That's at this level, right here, no problems. Using very occasionally, maybe once a year at most. But then you start having fun with problems. That happens around here. And as it progresses, it's just problems. So by the time one gets to moderate and certainly severe substance use disorder, which would be addiction, then you have the problems. And all of this is gone by the wayside. Now, what happens with meth users is you remember the fun, you forget the problems, so you start feeling better after a day or two, and you try for the next X amount of years, maybe it's 1 or 2, maybe it's 10, to get back to problems. But once you've moved to get back to fun, but once you've moved to problems, you never get back to just fun. So what I'm going to present here today, following all that background information, is what I've done is track methamphetamine use and other substance use in LA County among MSM for 19 years here. And we've had 3 cohorts that we're looking at. We used a quasi-time-space sampling methodology through street and venue-based outreach methods. So we worked with MSM, who used substance, alcohol or any other drugs in the past 30 days. This is important because what I'm presenting here is not the epidemiology of substance use among all MSM in LA County. This is specifically among substance users. So if guys on the street or in bathhouses or anywhere where the staff goes report that they're not using substances, we've removed them from this data set. We want to know what substances substance users are using. So we're in Hollywood and West Hollywood. No matter how often I review my slides, there's always one typo. So this is not 5 p.m., this should be 1 a.m. And we go to the streets and bus stops and the cruising areas, bathhouse, sex clubs, anywhere we can find users, Hollywood, West Hollywood, and sometimes in downtown LA. We give them gifts as a way of developing trust and rapport with everybody. We start with a contact with just a few minutes, 1 to 5 minutes, to just introduce who we are and what we're doing. Then we go into encounters where we have these longer, in-depth discussions about their needs. We get the drugs and sexual risk information, and these can last up to 60 minutes. The average tends to be about 20 minutes or so. All of the data that I'm going to be reporting on comes from the encounters, and then of course we make referrals as needed. So we've had 3 cohorts that I'm going to talk about today. Cohort 1 was from 1999 to 2007. Cohort 2 was 2008 to 2011, and Cohort 3 was from 2012 to just a few months ago. All of the cohorts have used the same methodology to meet with the users on the streets or in high-risk venues. The data is organized into 6-month periods. We, again, deleted those that had repeat visits, persons not reporting substance use or did not identify as MSM. So this is first time use that we meet with somebody. First time we have an encounter with somebody. That's the best way to track what the trends are. So we had an analytical sample of just over 25,000. We got rid of the repeats. We got rid of people who did not report substance use, who are not MSM. And that gives us our final. So here, okay, this is a little bit about street-based outreach. And here's the Socio Demographics. The age has stayed pretty consistent. There has been a change in the ethnicity of the folks that we've talked to, the race and ethnicity, slight decrease with Caucasian, white MSM, an increase in African-American MSM, a decrease of Latino, Hispanic MSM. There has been an increase of those who identify as bisexual as opposed to gay. We've seen more fluidity of sexual identity in our center over the last 5-7 years, just as we've seen more fluidity with gender identity. And the HIV positivity rate has gone down. We find that very interesting. Okay, so now we're going to start looking at the data. The black line in all of the graphs that I'm going to present is methamphetamine. Alcohol is always the most highly used substance, followed by marijuana, and then followed by methamphetamine. So you can see that in the first cohort, it's kind of all over the place with a peak here around 2002. Then there was a dip, and then it started to rise again. So I originally decided to do a second cohort study because I wanted to see if this rise was going to continue, and if so, how far it was going to go. So I analyzed the data again to see if we're going to continue around this 25%. And again, that's 25% of everybody who's, every MSM who's using a substance, 25% of them, a quarter of them are using meth. So when we look at 2008 to 2011, my suspicions were correct, and that rise continues, but interestingly, it stayed stable. So for this entire observation period, we're between 23 and 27%, but a continual rise here. So when I knew this, a meeting was happening, I decided to go back and look at the data again. So I picked up where we left off here last in 2011 and started looking at the data from 2012 to December 31st, 2018. And again, we see the rise because it ended at 27% in 2011. Now we start at 29%, and we stay consistent at hovering between 29% and 30% throughout this entire observation period. That's very interesting because that's what's telling me that the guys, again, MSM, who are using substances, close to a third of them are using meth. Now, what's interesting is right here, this is the spike in non-heroin opioid. This is fentanyl, this is oxy. Right here, it went from a zero, less than 1% to 4.5%. That's a 400% increase in opioid use among MSM over this observation period. I think this is important for us to recognize and pay attention to. So I decided, let's look at what happens when we break this out by positive and negative guys. When you look at the HIV positive MSM, the methamphetamine use jumps from where it was before, between 29, 28, 30%, they're using about 10% higher, the MSM positive guys. They're all in the 40s, 42%, 40%, a couple at 39, but a good 10% higher. And 6% for the opioid use, increased in both. You look at the negative guys, they're down here at the 20%. That's still high for substance use. Let's not pretend it isn't. But the positive guys are using twice as much meth as the negative guys and twice as much opiate use than the negative guys. So then I thought, let's look to see if there's any racial ethnic differences. And we know, those of us who've been doing this work for 25 years, it was always a discussion about how the Caucasian guys were using meth and the African-American Black guys were using crack cocaine. But that's not what the data shows us. This red line here are the African-American guys. The African-American Black MSM are using more meth. The blue line is Caucasian guys. The green line is Hispanic Latina guys. So what does that tell us? Well, meth continues to be the most frequently used substance among MSM following alcohol and marijuana. It has not changed since 1999. We look at these cohorts and we see that it has consistently increased throughout the entire 19-year reporting period. In cohort 3, we observed that positive MSM consistently used methamphetamine at higher rates than the negative MSM. We see that in cohort 3 that unlike previous studies, the African-American Black MSM are using higher rates than Caucasian White or Hispanic Latino MSM. Very disturbing and alarmingly, we must pay attention that heroin use remains steady, but non-heroin opioids like Oxy and Vicodin and, of course, fentanyl increased by 400% from 0.08% in the first half of 2012 to 4.5% in the second half of 2018. And that increase was consistent and steady through that entire observation period. And that opioid use, like methamphetamine use, was higher among positive MSM than the negative MSM. And also, let's not forget about other populations. I think that the substance use trends that we have documented through the street outreach is an ideal mechanism to show us what's happening in the community and can be adopted with other populations. So we have an opportunity here to have a brief discussion about implications for interventions and for policy makers. So given the documented link between methamphetamine use, sexual risk behaviors, and HIV infection, there is a compelling need for ongoing methamphetamine and HIV prevention interventions to both positive and negative MSM. There should be interventions for both African-American, Black MSM, Caucasian MSM, Hispanic Latino MSM, but all of these interventions need to be culturally responsive to their particular target populations. The behavioral interventions that are focused on reducing meth use should also focus on reducing sexual risk behaviors, given this association that is linked and it's solid. And to just focus on the meth use, you're risking missing the sexual risk behaviors. And then HIV continues. We also need to include interventions that focus on increasing PrEP uptake and adherence, treatment as prevention, and U=U strategies. The use of opioids in this population is a call to action for policymakers and our community partners. We need to pay attention to this. Naloxone saves lives. There should be kits available and training how to use it to all who work with opioid users. And how about fentanyl test strips? Give them to the users, community workers and outreach workers who are out on the streets and meeting anybody who reports any substance use, but most particularly any opioid use. Give them a fentanyl test strip, show them how to use it so they can test the drugs that they're putting into their bodies. It's basic harm reduction. Let's try to keep users alive. Should note that these test strips are very, very sensitive. There is a high rate of false positives. That's good. A false positive is fine. And there's a minimum rate, much lower rate of false negatives. But the goal here is we have the data, we see the drug use that's in our community, we see what's going on. Let's do something about it. Our goal here is to save lives. Let's all work together to reach that goal. And if anybody's interested in reading more, here are the references to all the papers that I just presented on, that Steve and I have worked on this for the last 25 years, and these are all available online. Thank you.
I wonder what your opinion is about using mental health as a prevention tool, as a strategy. I often find that in mental health, sometimes when you said today right now that sometimes we can focus on the substance use and we have to look at risky behaviors. In mental health, I always find treating substance use and risky behaviors, but also everything that came before the substance use even started. And so sometimes I wonder, why don't we have funds or a strategy to provide mental health as a strategy to prevent the substance use, rather than treating it all together, which can be very overwhelming. I sometimes find that, like in the culture with Latinos, if we were to address family rejection, cultural beliefs, acculturation, all those things, then maybe we would see the prevention of substance use. What is your opinion about using mental health as a prevention tool, a strategy, versus just a service? Most of the prevention programs out there are like 1 to 5 sessions or a certain workshop, but it's not really like a mental health treatment.
Well, I'm going to attempt to answer that question, but I will preface by saying I am not a clinical psychologist. I am a researcher. Steve's a clinical psychologist, so he might want to add his 2 cents in here, because Steve likes to add his 2 cents into everything. So we'll give him another opportunity. Mental health services are always good. You know, but there are restrictions, and there's policymakers in the room, and you can talk to them about the restrictions and the funding limitations for programs. But when you're looking at prevention, you need to go back to really young ages. You need to go back into the schools if you're looking at prevention, because most of these guys start using at a very young age, and they're involved in heavy meth use in their 30s, but they've already been using for 8 years and 10 years. And a lot of them start using as late teenagers and early adults. So prevention work, if you're looking at prevention work, you've got to start much earlier. And if prevention work could start looking at some of these dynamics and maybe abort some of the use, that would be fantastic. But you can't take that outside of a cultural context. So if you're looking at MSM use within a cultural context. They use within bathhouses and sex clubs and with friends, and it's all associated with sexual risk behaviors. So you can definitely add mental health into that mix of prevention strategies, but you cannot take it outside of the cultural context of what it means to be a MSM, either gay identified, bisexual identified, or heterosexually identified who have sex with men, because that's the context that they use in.
Hi, over here, just wanted to say thank you for the informative presentation. I actually had 2 questions.
I'm trying to see who's talking.
Over here.
Oh.
The first one is your opinion. Where do you feel the uptick in the non-heroin opioid? Are they new users to opioid, or are they coming from the meth users?
Yeah, I think it's coming from the meth users, and it's coming out of availability. If you look at when the uptake started, it's really, it's the data combines non-heroin or opioids, but it's really the fentanyl. And it's the availability on the streets, and it's being, just widely accessible, and the data just completely aligns with the rates of increased opioid use with other populations. So.
Thank you. And the second question I had was, have we gone nuanced to look at the actual specific ways methamphetamine was used? What I mean by that is, obviously, if it's used, needles is how they share.
Yeah.
Have you differentiated between people who just smoke it versus people who inject it?
Oh, we have decades of data that breaks it out by the route of transmission. And most of the guys smoke it as opposed to inject it, but I'm not sure what you're asking, but are you asking, are there different outcomes? There were not really different outcomes by the route of transmission. Is that what you're?
Not today. Both of them had people fortunate positive.
Yeah. And the reason why, and this is in the early report that Steve mentioned that I did in 1995, is because of the sexual risks involved in taking methamphetamine. So it's not the injection risks of using, sharing needles or something. It's the sexual risks when they use methamphetamine that transmits HIV. So the outcomes are the same. Anyways, thank you for your attention.
Thanks, Dr. Reback. That's awesome. So I appreciate the comment about mental health. That's actually really helpful in your comments as well about how this all fits together in people's lives. I want to start those conversations. I don't have time for that, but your idea about what's happening with injection leads us right into the next presenter, Ekow Sey, who is with the LA County Department of Public Health Division of HIV and STD programs as a supervising epidemiologist. I actually got a chance, Ekow, to see your slides, and we are in for a treat. So actually, it's not a happy treat, but it's a treat. He's had over 20 years experience working in the field of public health and HIV, and he'll be telling us today about what he's been seeing in LA County on behavioral surveillance of hard-to-reach populations and cost effectiveness of how we might think going forward. Okay?
Well, I haven't gotten to the point of being able to earn a hug from Dr. Shoptaw, but we're getting there. We're getting there. I'll have you know that in the years that I've been working, especially with behavioral surveillance, we had to each time during the formative work, reach out to subject matter experts to help guide us in the work that we did. And we would always reach out to Dr. Shoptaw, and he's a very busy man, but yet he would take our call and answer these arduous questions, some of them not so great, that we would ask to help guide us. And I really do want to thank him for doing that for all these years. So my name is Ekow Sey. I work at DHSP under the guidance of Wendy Garland and Mario Perez, who helped shape some of these ideas and shape some of this presentation. Over the years, I've learned that if you have a 25-minute presentation and you want to weasel out of questions, you show up with 20 slides. So today I showed up with 60 slides, wasn't leaving anything to chance. But I'm going to talk about trends in meth use among at-risk populations in Los Angeles County. Let's see here. It doesn't work itself? Oh, okay. Oh, I see. Got it. Thank you. Well, I don't think I need to establish or even argue about the importance of the meth uptick that we're seeing. I think that has already been done. But if there was still the need, this is national data showing drugs involved in overdose deaths between 2000 and 2016. And I hope you can see it, but you see the methamphetamine uptake right there in overdose deaths. And so the phenomenon is a real one that we're experiencing. I'm going to be focusing my discussion mainly on the trends in meth use in LA County among people who inject drugs. There's a reason for this. In National HIV Behavioral Surveillance, NHBS, we monitor indicators among different at-risk populations. Now, we monitor the behaviors among men who have sex with men, but as a general MSM population and the general heterosexual population. So when Cathy was speaking, she spoke about specifically MSM who inject drugs. Now, the surveillance that we did was not designed to be able to say things about that specific subgroup. You know, you have less than 5% of MSM as an entire population injecting drugs. And so when we survey the general MSM population, you know, for example, we get just 29 each cycle who actually inject drugs. And so we don't have the power in, you know, NHBS to really say so much about that subpopulation of MSM. We can say things about the population of people who inject drugs. So this is going to guide where I feel I can tread and where I don't. I mean, I will make some statements about what we are seeing among that very small population of MSM in our sample who also injected drugs. And we are seeing the same things that Cathy alluded to or spoke about. Very quickly, because of the time constraints here, National HIV Behavioral Surveillance started in 2003. It was created basically to conduct surveillance among persons at high risk for HIV. The objectives are to monitor HIV prevalence and trends in behaviors. We collect data about risk behavior, HIV testing behavior, HIV seroprevalence, HBV, hepatitis B, hepatitis C, seroprevalence, and exposure and access to HIV prevention services. It's conducted all around the country. There are about 23 jurisdictions, including Los Angeles County, who are funded to do national HIV behavioral surveillance. I already indicated the target population, and I'll let this go in interest of time. NHBS is conducted in annual rotating cycles. So you have each third year, the same population is surveyed. So you have the MSM population, men who have sex with men. The next year you have the injection drug using population. The next year you have the heterosexual population, and then we return to the MSM population. And so we're able to, every 3 years, we come back to one population, and we're able to see, well, have things changed from previously. Also, I'm going to just breeze through this. These are eligibility requirements for those who are interested. Generally, individuals have to live in Los Angeles County, 18 years and above, and able to complete the interview. And then we have population-specific requirements, and specifically for the IDU requirements, they have to report having injected drugs that were not prescribed to them in the past 12 months. They have to actually have evidence of injection that is either physical signs, you know, we actually inspect track marks, or have an adequate knowledge of injection. What happens, especially when we do this work with people who inject drugs, we end up in areas where the folk who are hard up and there's motivation to try to get into the study. So we have to make sure that we are limiting it to those who are actually users. Quickly through the sampling approach, NHBS uses time location sampling to sample men who have sex with men. This is not the time to go deep into that. Responding driven sampling is what's used to sample people who inject drugs. And responder-driven sampling is like a snowball sampling methodology, but it has this caveat where, you know, there's a limit to how many individuals any specific person can contribute or bring to the study. So we place sort of a quota in the amount of a referral that one individual can make in order to sort of prevent any one person having an undue impact on the composition of the sample at the end of the day. And I'll leave it at that. Responder-driven sample has some issues. Definitely has some issues and limitations. But I walk away from it thinking, you know more after talking to 500 people who inject drugs than you knew before you spoke with them. So even though there are some issues and limitations, I think we come away from this with more information than we would have otherwise. The sample size for each cycle, each year of NHBS work is about 500. And the interview is conducted in the mobile van. Participants get reimbursed for participation. I'm speeding through this because I'm just trying to get to the results, and because I think that's what we're probably all interested in. HIV prevalence by target population, of course, the prevalence of HIV among MSM outpaces all of the other populations that we look at, ranging, you can see here, from a low of 16% to 21%, and this has been consistent over all the years we've observed. Among people who inject drugs, the prevalence has consistently been below 5%. And I'll have some statements to make about that, at the end. I think it's easy to get complacent. And maybe we have, because the prevalence has stayed stable below 5%. National data, this is national data for NHBS across all the 23 sites. And you can see that post 2012, we are seeing that increase in meth that I think has brought us here today. The green line, you see an increase in the report of meth use, and this is injected meth use among people who inject drugs, and this was all around the country. Now, specifically in Los Angeles County, our data is showing, and that's the your blue line for people who inject drugs, that between 2008 and 2018, you're seeing this increase in non-injection meth use from about 32% of the respondents saying they use non-injection meth to 75% saying they use non-injection meth in 2018. So a dramatic increase there. I do want to focus more on injection meth, where in 2008, 2010 round, we are seeing 29% of our people who inject drugs, respondents, report injection meth use to 68% by 2018. So there again, you see a significant increase. Now the real question becomes, is this a real increase, or is this basically an artifact that is influenced by the composition of your sample? Is the underlying sample changing year upon year? And that might give rise to the increases that you're seeing. So we didn't just take this as face value. We said, okay, let's see what the composition of the sample is year on year, to see if there are any changes that are responsible for this increase, or is it a true increase? And just briefly, I don't know if you can see the numbers from what you're saying, but if you look at the male-female breakdown throughout the years, it's remained fairly stable. You have about what I call the 70-30 split. About 70% of the sample is male and about 30% of the sample is female. I mean, why would this be important? Well, generally we see more meth use in males than females. And so if the sample, composition of the sample is changing and becoming, more male, it would be, forcing an upward pressure on our estimates, and we would want to know it. Race, ethnicity, looking at the distribution over the years, the change I would say is in the white population starts out at 23%. The first time we surveyed the population, 28% the next time, 30% the next time, 34% the next time, 42% the most recent time. And so you see an increase in the composition of whites in a sample. And if whites are more likely to use meth, then you would think, okay, maybe this is influencing these higher estimates that you're getting because the composition of your sample is changing from year to year. Another thing I want us to look at is age. And we have broken this down to under 30 years versus 30 years and older. And you see the under 30 years, about 5% in the early years, and it increases to about 22% in most recent years. So here again, you see some changes in the underlying composition of our sample. And like I said before, we generally see meth use is elevated in males versus females, and this we have seen to be a trend that stayed true throughout our observation period. As far as race is concerned, I mentioned this before, we have seen white people who inject drugs elevated meth use compared with Latino and Black. And this is not in contradiction to what Cathy was reporting, where she was talking specifically about MSM. She was talking about specifically MSM who use drugs. This is referring to the general people who inject drugs population. Here we're looking at by age group, and I do get fixated on the under 30-year age group. But here again, you see elevated meth use in the under 30 years of age group as compared with 30 years and older. And this is consistent throughout the years. And, this was something that we saw as well. Among homeless, currently homeless, we also see elevated meth use, and it's consistent throughout the years. So really, the point is that we did have changing dynamics in the underlying population. And those changing dynamics, some of them, of course, we have more youth than we did before. And if these younger people are more likely to use meth, maybe that is what is influencing the increase that we're observing. So what we needed to do was to adjust the results, right? To see whether the increase we were observing was a real increase, or whether it was only a result of the changing underlying population, the distribution of the population. So we created a model which basically adjusted for age, race, gender, and homelessness. So the point of this slide is saying all other things being equal, when we take away the effect the changing composition of the sample has on our estimate, we still see an increase in meth use over the years. So that was a charge to look at NHBS data and see whether it provided any evidence that in the people who inject drug population, there was actually evidence of an increase in meth injection over the years. And after going through that whole process of trying to rule out all the elements of the changing sample dynamics that would impact observation, we still find that this appears to be a true increase that we are observing. So I guess what does that mean to us? In particular for me, seeing these young people who inject drugs and the elevated meth injection among them definitely raised my eyebrows, particularly because young people who inject drugs are more recently initiated into drug injection by virtue of their age. And I think they better represent what the recent trends in drug use injection are. I mean, they're the future of our drug using population. Our drug using population has for years been an aging population. And in more recent years, we are now seeing these younger injection drug users come into the fold. They're more likely to engage in high-risk behaviors for all the reasons that Dr. Shoptaw gave, because they're more likely to use meth. And that brings along with it an increased likelihood of engaging in high-risk behaviors that place them at risk for HIV. And in terms of thinking about prevention, they're less likely to be HIV positive. I mean, these are young folk, they're less likely to be HIV positive. So they are a very important target for our prevention effort because there's still an opportunity for us to intervene. I think it's easy, especially when you see the stable HIV prevalence in the IDU population, to get complacent and think, we got this. I think you only need to look back to Indiana to realize how rapid HIV transmission among the IDU population can in fact happen. I mean, it has recently. And these changing dynamics that we are seeing are cause for concern and a rallying cry for us to act. And did I make the time? With that, I'll say thank you very much.
What is the amount of co-use of heroin or opioids with your methamphetamine injectors?
Oh, okay. Trying to see if I can remember what the number was. We did ask that question. We saw increases just as we did. It was almost, if I remember right, it was almost all the individuals who reported meth use were reporting opioid use as well in this population, right? And you just reminded me of one thing I should have said, which I didn't before. I didn't want to comment so much on our MSM population, PWID population who were also MSM, because I said the sample size was so small, there were just 29 of them. But I make this comment. Of the 29 individuals, and that's generally what the number is year upon year, who we sample in the IDU cycle, about 96% in the most recent cycle reported meth use. So that is, that's just 29 people. I don't want to make that inference, but it is certainly lining up with what Dr. Reback presented.
Thank you. Good question.
What is the existing data on women and children and meth use? So children being born to women who are on meth, what does the data look like? Because when you collapse heterosexuals, women and men, they really need to be separated. I know Dr. Spencer's seeing more women than ever. Recently coming in, women, she said that she would never have suspected or she was surprised. We've seen women at UCLA. Susan sees women. Women have been mentioned 4 times today, and that population, when you talk about being complacent, I think we need to include them, and we can't just continue to collapse women into every category accepted.
I absolutely agree. I do know that among the mothers of babies with congenital syphilis, we've seen like a really high proportion of the mothers reporting meth use. So what you're alluding to is real. The limitations of national HIV behavioral surveillance is that it looks at these general populations. This is the 40,000 foot level. And so you generally are able to say things at that generalized population level, and you don't have the power to be able to say things about, very important subgroups. I mean, I think what you're raising is, underscoring the need for us to have some of these efforts that are directed at some important subpopulations that we know are important. It's been a funding issue, I think. It costs, $600,000 plus, each year just to sample 500 people. And I think that's where the problem comes in. If we were able to, into the 500 people, which cost the 600,000, sample, several thousands, we would be able to say something about the subgroups. So we need to find a way. Where there's a will, there should be a way. But I can't disagree with you.
I just hope we don't leave today with call to action and leave the women out of it, because
I've got it. We got you. And I just want to say something. I live in a first world city where there is a third world city here. There is one here in Los Angeles, and your comment about congenital syphilis is unacceptable. There is absolutely no reason for a baby to be born in Los Angeles County, whether it's methamphetamine related or what, with syphilis. So I just want us to get righteously indignant about some of this stuff as it affects reproductive health and the ideas of substance and gender. I actually endorse that. I think we'll be continuing to develop that point. Thank you for bringing that up. We're going to break until 10:45. In that spirit, what I want to say is that there is a need for talking among ourselves. And today is not meant to be the end of this discussion. It's to begin to start the discussion. One of the reasons why we all want to talk is because it's been over 10 years since we really paid attention to methamphetamine in our communities. And we feel the need because the need is so strong out there in our communities. So I appreciate everyone spending time with each other in the hallways and on the sides of the meeting and talking across your table, making new friends, making new connections. I look forward to things growing out of this. In that spirit, one of the things I would ask is if you didn't sign in, please do. We plan on following up with you after this is over. It's our commitment to fulfill the pledge that this is the beginning of the conversation, not the end of the conversation. There will be meetings after this. I will be hearing more about that as the day progresses, but we want to make sure that everybody understands that we love everybody talking about everything, and we want to continue that because that is the strength by which we're going to meet this challenge. And then just to remind folks that if you are getting CEUs, that you do have to sign out at the end of the day. So moving on to our next presenter, it's Dr. Lello Tesema. She's the Associate Medical Director for Prevention at the LA County Department of Public Health Division of Substance Abuse Prevention and Control. We were talking at the break, one of the wonderful things that's happening at SAPC, as we like to call it, is a tremendous change in direction. And the direction is very welcome, at least from my desk, focusing on things like evidence-based care, implementing medication-assisted therapies, thinking about prevention and getting things out onto the streets, thinking about jails. There's a lot of really important work that SAPC is doing, and I look forward to hearing what she has to say. Prior to joining SAPC, Dr. Tesema was the Director of Population Health in the LA County Correctional Health Services. Her interests are about harm reduction, the crossover of collaboration in addressing social determinants of health, and public health advocacy for the county's justice involved. So I'm going to turn it over to Lello. Look forward to your talk.
Thank you, Steve. Thank you very much, Steve, for the introduction. Thank you for inviting me. This is a really exciting and dynamic forum. I'd like to add that before, I'm a primary care physician, and before joining SAPC, I worked at the jail, and I've been working at the jail since or working with criminal justice involved populations since I've been a medical student. And so this is a space that is very, very near and dear to my heart. And it was staggering to me how overrepresented people with meth use disorders are in our jails in LA County. I mean, it is really, really mind-blowing. And so I urge this group, as you think about special populations and interventions for special populations, that you keep those who are justice involved as part of that dialogue, as key stakeholders in the work and the mission that you're trying to accomplish. So a quick poll for the people in the room. What percentage of people treated for substance use disorders in LA County are treated for a primary meth use disorder? How many would guess it's about 5%? By show of hands. How many would guess it's about 10%? I see some hands in the room, maybe about a third. 20%? 50%. Sorry, 40%. Thank you for correcting myself. 40%. Okay. So I'd say a split between 40 and 20%. So it's actually about 20%. This is not necessarily reflective of prevalence data. It's who's accessing treatment. And as we've heard from speakers, before me, that there's definitely a treatment access gap between who needs treatment and who's actually getting it. So this is by no means a reflection of the burden of the issue within our county. So in the next 15 minutes or so, I'm going to briefly go over epidemiologic trends of meth use disorder in LA County across all populations, not just special populations. Some data that we have at SAPC on utilization and what we offer in terms of treatment. And at the end, actually, I would like to engage the room in discussion on what we could be doing more to enhance treatment within the county for people with meth use disorders. So I'll be asking you questions instead of you asking me questions. So just briefly, some epi trends. So domestic meth seizures has gone up substantially in the past decade in LA County. And so has the cost of meth has actually gone down substantially. So per pound cost of methamphetamine was about $8,000. Currently, it's down to $2,000 to $3,000. We know that market price is associated with availability. So what this is telling us is that there's increased community saturation, if you will, of methamphetamine, largely driven by a drop in cost and increased supply. Meth-related overdoses, and this is county-wide, this is our SAPC data, has also grown substantially, both as an absolute number and as a proportion of drug overdoses that are attributable to meth. So meth-related overdoses have gone up about 700% in the past decade. That's staggering. This is largely due to multi-organ failure, cardiovascular compromise, and so forth. And as a proportion of drug overdoses, that has gone up about 500% in the past decade. The public health toll of methamphetamine use and misuse is also seen in the increase in fatal motor vehicle crashes that we see that have also grown substantially in the past decade. What do we know of healthcare utilization? Well, meth use has a swelling economic toll, and this is largely driven by healthcare utilization. So this has grown from about 200 million about a decade ago to $1 billion. And just for additional context, this actually rivals the healthcare utilization cost of opioids. So the healthcare utilization cost of opioids is about $1.8. So there is, I think, perhaps a misconception that opioid use is associated with a higher healthcare costs, but they're actually quite similar. Meth-related hospitalizations and ED visits have gone up also substantially in the past decade, about 600% in terms of hospitalizations and about 300% in terms of ED visits. Meth use, and we see this more recently, is associated with higher ED visits, but fewer hospitalizations. in comparison to opioid use, which is associated with higher hospitalizations. And this just has to do with the treatment for the withdrawal and the nature of the kind of acute illness, if you will, of intoxication. But we know that ED visits are not only costly to the healthcare system, but they're also incredibly disruptive to people's lives, to their recovery, especially if interventions aren't offered within the ED when they come in and acutely intoxicated. This is some treatment data from SAPC. So we service all people in LA County that are Medi-Cal eligible or are currently on Medi-Cal. And so this is treatment data for this public safety net population. So about 21% of the people that we see in our system have a primary meth use disorder. And again, this is not correlated with prevalence. We have seen a slow increase in the number of people and the proportion of people that we see where we are treating for a meth use disorder. The majority are male, about 55% are male, 45% are female. Somebody earlier had alluded to kind of special populations and considering women in the dialogue of sort of special populations of the data that we acquire. I know from having practiced in the jail that there is an overwhelming prevalence of meth use disorder among women in the criminal justice system that is probably underestimated in our current data. But certainly this reflects the aggregate of who we see, but within certain special populations, we do see a predominance of women with primary meth use disorder. Within our system, about 2/3 are Latino, followed by African American, followed by Caucasian, and then followed by African American. Again, because we service the public safety net, the majority of our clients have few advanced degrees, so most have not completed high school. About 80% are unemployed, most are not actively seeking employment, and about 1/3 are homeless. So you can imagine how this creates unique challenges for us as a kind of wraparound delivery system to provide not just substance use care, but to provide wraparound services that support people's transition back into the community and back into living a productive life that is substance-free. Our compliance rates for treatment, and so this is people who are admitted to treatment, who complete the treatment as indicated, is a little shy of 50%, so it's about 47%. This is far below our target, and so I'd be curious to hear from people in the room how we as a delivery system can enhance this data, because this is certainly unacceptable to us. And so what do we offer for treatment? So as Steve had alluded to earlier, LA County is unique in that we operate under a drug Medi-Cal waiver that essentially has transformed us from an SUD specialty system to a managed care model, which cares for the people in LA County that are on Medi-Cal or are Medi-Cal eligible. So we provide treatment. This has allowed us to expand our SUD services throughout the county. We have about 400 agencies that we contract with that provide treatment. It has also allowed us to expand our medication-assisted treatment for people and within our network, and have increased reach into hard-to-reach communities such as MSM, criminal justice involved, LGBT communities. There are several pathways to enter our system. There's no right pathway. They all lead to ideally placement that is expedited into our SUD treatment network. So the first pathway is our SASH line, or our Substance Abuse Service Helpline. This is a line that we developed that is a 24-hour, 7-day-a-week line that anyone can call, either a provider, a client, a family member, a caregiver can call this number, and they get initial screening. So this avoids the need for an in-person intake. So it removes that additional barrier to entry. And then based on their treatment needs, would place them into treatment. The second entry system into our treatment network is through our SENS system, which is our client engagement and navigation service. This is a service that we contract with that is really targeted towards clients who interface with multiple different county entities, predominantly the criminal justice system, but also DMH, DPSS, and other entities. So the goal is to coordinate care, to provide kind of active client navigation and entry into treatment as well as follow-up. The third mechanism, which is less common, is a direct provider entry into our SUD network. So I mentioned this is our SASH line that is available to anyone, clinician, non-clinician, family member, caregiver to call, and an intake is made and a placement is made as indicated based on their clinical criteria. We also developed, in the spirit of sort of leveraging technology to increase access and placement, a service and bed availability tool. So this is a publicly accessible web-based locator for SUD services, and anyone can access it. It's on our website, on our SAPSI website, and you can filter it by the level of care. We are trying to make it as culturally relevant as possible, so you can filter it by language capabilities, by access to medication-assisted treatment, different special populations. And this shows us, and is publicly available, what beds are available for who and where. So again, this is a publicly accessible domain that its goal is to really create transparency of who gets placement and where and for how long. The last thing I want to touch on is prevention. So somebody had alluded to earlier, actually I heard several comments in the room, what is the role of prevention? What is the role of early interventions to really curb the epidemic? And there is no shortage of research to support that prevention, early intervention, perinatal interventions, early childhood interventions really modify the course of people's lives and their likelihood to develop substance use disorders. So in that spirit, we have launched two sort of major prevention initiatives within SAPSI. One is a student well-being center. So we are launching 50 student well-being centers across the county at what we've determined to be high-risk high schools. And these student well-being centers will be staffed by health educators that provide SUD education, referral to treatment as indicated, other wraparound services, including reproductive health, STI testing and treatment. But really the goal is to meet risk as early as possible and to target interventions as early as possible within high-risk young adults or youth. The second major initiative are family resource centers that we've called our core centers. These are connecting opportunities for recovery and engagement. These centers will be launched throughout the county. The first one will be launched this summer at LAC USC's Wellness Center. And these are a walk-in service for anyone to come in, get resources on SUD, get connected to treatment, get overdose education, naloxone if needed, and other wraparound services, including housing, transportation, and so forth. So really trying to identify individuals and families that are either at risk or currently impacting and provide them with resources and referral to treatment. There's a lot more that we can do in the prevention space, I recognize that, but these are two areas that I think are sort of population level interventions that are trying to address risk in the spectrum or continuum of SUD risk. So with that, I want to say thank you, and I open the floor to questions.
Hi, and thank you. My name is Missy, and 60 days ago, I walked into outpatient and I asked for help because I was aware that it was available. However, when I was out there, I would get real loaded, and then I would go down to the riverbed and I would encourage health checks, and I would bring clean needles, and that's the things that I would do to try to make sure that people knew. And one thing that I found out while I was doing that was people are in fear of incarceration, so they don't ask for help. So maybe if we would make it more available when people go to the welfare office or the GR office to know that they're not going to get arrested, that they would be more inclined to ask for help.
Thank you, Missy, for that question or comment. I really appreciate it. There is certainly a lot more that we can do with educating our law enforcement colleagues on what drug addiction really is, sort of broadly and philosophically. But specifically with respect to clean needles, like one of the areas I oversee is our needle exchange program. And I know from hearing stories from our clients that confiscation is very common, not just for needles, but also for naloxone. And so this is something that we are really taking very seriously, and we've given talks to our law enforcement colleagues on what is, within the legal bounds of confiscation, what isn't, but there's a lot more to go, and so I really appreciate your comment. Thank you.
So I know SASH helps people that are with Medi-Cal, but how about for folks that don't have health insurance, maybe because of their legal status? Is there anything that we can do to put them in some sober living or something?
That's a great question. So SASH, so we support people that are either Medi-Cal or Medi-Cal eligible. For individuals that are not on Medi-Cal, that maybe have health net that are undocumented, I'm not sure what the scope of services available are, to be honest with you, but I can look into that and get back to you. Thank you.
Hi, and to piggyback on that question, what's available for the group of people who I call the tweeners? It's like their insurance is just okay. They can't afford to, say, go to beautiful passages in Malibu, right? But they don't have nothing, so they're not don't qualify for free substance abuse treatment. Like we find it challenging where to send folks, because then they, there's still a huge out of pocket.
Sure.
And the will is there, but it's a big challenge.
Yeah, no, I certainly echo that. I mean, it's the whole donut phenomenon, right? Like you either qualify for all services or really robust services, or you're stuck in the middle. And, for people who have employee-based insurance or really high premiums, that's a challenge. And for that, I would think, as a community, I think advocating to our lawmakers that this is unacceptable, that, STD treatment for people who are privately insured but underinsured needs to be made more accessible. But unfortunately, this is that sort of donut phenomenon that, our privatized health insurance system created.
Thank you. If anyone in the room has any suggestions, please pop by. Thank you.
That you're going to have the donut effect also with campus, because if you've got teenagers that are under parent policies and not under their own, again, the high deductibles, you sort of in the same scenario.
Yeah, well, for teenagers,
Can you repeat the question, please?
Yeah, sorry.
On the campus, you're probably not getting one on the campus.
On the schools, correct, yeah.
On the school campus, you're going to have students that are underage still falling into that same donut effect.
So for children, they should be all eligible for insurance. So they're under the parents' policy.
Their parents are high deductible, but they've got to continue to the parents, and that's when you've got.
I see.
It's still wanting to hide the fact they're using.
Your point's well taken.
But I just want to piggyback on that question and say that don't youth in the state of California have the right to access confidential medical services without their parents' permission, and that includes substance use. I know about it because they can do STD care. So would that, and I don't understand what substance use, would that, by them being able to access those services on their own, would they then maybe qualify for some type of Medi-Cal or coverage? under our system?
So, you know, in our experience, and I don't oversee the youth system of care, so I'm speculating based on what I've seen, is that for youth, when youth directly access system, which they often do through our SASH line, if there's somebody else who works in the youth system, then please, you know, keep me honest, is that they're considered emancipated minors.
Right.
And so they are able to access treatment services, you know, independent of their separate insurance. But I'm not sure what the mechanics is of actually them getting on insurance. If somebody else can comment, that would be helpful. But we have never had instances where youth were not able to access treatment because of insurance issues or having to disclose their condition to, you know, an adult. But I'll look into that. But that hasn't been our experience.
Hi, my name is Irene. I'm with Children's Hospital Los Angeles.
Oh, great. Thank you, Irene. I was hoping you'd be in the room. Yeah.
We saw a drop in young people accessing services because they were covered under their parents' deal. But with California, we have minor consent Medi-Cal. So the only thing is that young people have to go and be seen in front of an eligibility worker on a monthly basis to get it reviewed. So that is like no questions asked for minors to access substance use care and mental health care and all the other reproductive health care. Now with regular Medi-Cal, same still holds true where the youth should be able to hold everything and it be confidential, but have yet to still hear from DPSS that for sure nothing would get sent home. So they're supposed to maintain confidentiality under regular Medi-Cal, but like again I said, if something gets sent home, there it is. So the absolute 100% sure way would be minor consent Medi-Cal, but it is a monthly burden on a young person to have to adhere with justification from their provider that says yes, continue the services.
So I'm going to end with the last question, and that is, can you talk a little bit about co-location of services, because most people who have substance use disorder also have some form of a mental health disorder. So can you talk a little bit about the commitment of your office to provide this coordinated care and what your thoughts are about how that might get boosted?
Sure, yeah, thank you for the question. So, you know, co-located services is something that we have taken on very robustly within our specialty SUD system. So in our treatment network, throughout each residential, throughout each level of care, we have co-located, or at least try to have co-located mental health care within the system, just because we know that comorbidity is so common. We also ensure that we train and staff our centers with people that are capable of providing behavioral health care in the complete sense and not just SUD specific health care. So just training of our workforce is something that we have taken on very seriously, just so that they can be agile and they can provide a wide range of services beyond just SUD treatment and counseling. There's still a lot more that we can do, not just with behavioral co-location, but with Hep C referral and treatment. That's something that we're working with our partners in the Hep C division of public health to try to increase referral to treatment and other chronic medical illness that we see commonly represented in our population.
Thanks, Ellen.
Thank you.
Well, I'm ready to go to work, but it's time for our panel to join us. So if I could have our panel members please come to the front. So first of all, I want to thank everyone for coming today. It's a very remarkable day. I want to introduce our panel. We'll start Charles McWells. He's the principal investigator and project director of Project 90, which is an HIV/HCV/STI prevention program for Black and Latino men, bisexual and trans people. He also is the community services manager at LA CADA's deep downtown LA outpatient program. He's an instructor with the community faculty program at Charles R. Drew University of Medicine and Science. He co-hosts for Good News Radio magazine and has been a tremendous advocate working within our public on substance use and HIV. To his left is Sandy McNichol. She's a project director for addiction clinical trials conducted by the UCLA Family Health Center, and she's part of the UCLA Center for Behavioral Addiction Medicine. She's responsible for developing and implementing research projects, supervises staff, goes out into the community, brings people into treatment, research opportunities, oversees a lot of regulatory compliance, and has been involved in the direct care, not only just research, but direct care of people with addiction problems for over 30 years. I met Sandy in the methadone treatment clinic. So this was back in West LA in Pontius a long, long time ago. And we've been working together ever since. So she has a strong commitment to working with people from the criminal justice setting and also in working with women. To her left is Angela Bartolome, a licensed clinical and social worker and the Integrated Behavioral Health Clinical Supervisor at St. John Well Child and Family Center in Mid-City area. She's the clinical lead of the Assisted Recovery Collaborative and is one of the leading clinicians providing mental health treatment for the diverse populations at St. John, such as the communities of recovery, transgender experience, reentry, and complex traumas. She comes from 15 years of grassroots community organizing, and that's her basis in looking to help the whole person. She'll be talking to us about folks coming from multiple intersecting minorities. Mike Rizzo is an LMFT, licensed marriage family therapist, and a certified substance abuse counselor. He founded the Crystal Meth Recovery Services and Addiction Recovery Services at the LA LGBT Center. And prior to that, was the program director of alternatives of a residential treatment facility in Silver Lake. He is our local expert and has a national reputation on crystal meth addiction recovery and has served on the LA County Crystal Meth Community Task Force and other community advisory boards. His work has been recognized nationally in The Advocate, GQ Magazine, and the Life and Times television series. So, with that introduction, I'd like to start by asking some questions. So, we've heard a lot today talking about the needs of women. Can you talk a little bit about how methamphetamine intersects with the lives of women to not only make them less visible on the street, but also make it so that it's harder for women to come into treatment?
The women that we see within the research that I'm doing with UCLA tend to be very just they're under the radar. Nobody's really dealing with them. Nobody wants to deal with them. There's a lot of medical issues that they're embarrassed to go and see anybody about, and their services just aren't available the same way, in many ways, as we can refer to the LGBT center. We don't have the same type of services within that we can send women that they'll go to because it's not a welcoming environment. There's a lot of judgment out there. There's a lot of things that keep them out of going to receive services. Low self-esteem, many of them are parents. They don't want to be reported to DCS. They don't want to have, they're already involved in health issues, so they don't want to have to make that worse. The legal system somewhat is an issue with them, but it's more of a parenting issue that sort of keeps them out of treatment. With the research, I really make it a point to bring in the women. I have a strong belief that women need to be represented in these research studies. But they're unique in trying to keep them in research because of their low self-esteem and because of the fear of being judged. It's a huge problem to keep them in the studies and in treatment.
What do you do personally to help a woman stay in the treatment research?
We will unconditionally work with them. We really, all my staff, works with the same group of people that we really want to be able to have people come in and be accepted for who they are, and we'll go to where they're at mentally, sort of where they're at in life, and work with them to move forward. We're not the answer to make them necessarily just stop using. But if we can plant some seeds along the way, they're very appreciative of that. They really like having the support of the other women within this staff who can help with unique ideas and help them with their parenting and just say it's going to be okay. Just that reassurance, I think would also use it. There's specifically with women, that's really important. We just need to know that somebody cares, that somebody's going to be there if we have questions.
So yes, I piggyback a lot of those thoughts and ideas. My background primarily is in community organizing, and one of my first groups that I started working with were women of meth use and their children. And so a lot of the work that I was seeing there was they presented with a long history of trauma, psychosocial traumas, falling through the cracks of every other system of healthcare, fear of their children being taken away. Very much one of the primary concerns. If I tell you I'm going to lose any sense of stability I have, these are all I have, don't let me lose what I have. This is already a strain of what presented. They may have come in because they wanted solidarity and having other women of meth survivorship, and to figure out how they're coming through this, through their survivorship. They also had to talk about the complex rape trauma that came with it, their untreated medical care. So at St. John's, we see a lot of the women that come in, primarily through the primary care providers. Secondary is through the behavioral health department, primarily because of referral from DCFS. And depending on how competent these providers are they more able to stay? Are they more flexible to work with the patients with their ongoing struggles? Like, yes, they might have been abstinent from any use for the past 6 months, but one day it was just too stressful and scary being a single parent with 3 children. And so that one day might have set them back a couple of years back into their traumas. So being ready and flexible to work with the complex issues of women, also often being the only reliable person to their children, only person that they have in the family that that is presentable enough to be well. A lot of times what I've also seen with women is it was a historical pattern of use from their mother, from their grandmother. Like historical traumas are also passed generationally, so is their substance use. So being very flexible and patient with the families that we work with, and knowing that if we work on our internal practice and destigmatizing these opportunities for people to come in, are they more likely to come back on a random Tuesday? Hey, I thought of you, I'm ready to come back today. Oh, you might have been gone for 3 months? Okay, great. When I see you, I'll see you down the hall. And it's like homie talk. But I have a hard time being always professional because this is just also how we deal with that.
I have a question. So to continue this discussion about the needs of women, it's interesting to talk about the place addiction fits in women's lives, how that interferes with their ability to seek care. But what about harm reduction? So do you have a few thoughts about like syringe and needle exchange programs, or high tolerance settings? How do the needs of women and the sort of things that they present with at harm reduction sorts of facilities present special challenges, or the things that needle exchange that need to be there that aren't, that address the needs of women? Just some thoughts about, even high tolerance housing, places where you could live, but not necessarily have to stay 100% sober to stay in the house. Any thoughts about that?
Are hard to find. Really hard to find. And they're hard also to get them in with their families. So a lot of times you have to figure out, okay, great. So I'm not going to ask we're all mandated reports, right? Most of us are. So we're going to have to be very mindful about the questions we ask that might entice a report. So that's part of my style of harm reduction. Yes, let's keep the children safe. Let's make sure that this is not impairing your ability to function. Let's also figure out, are you ready to possibly be separated from your kids so that you can put yourself first for one point of your life? So being that trusted person that they can tell you, yes, I'm using and I need to be ready. I'm going to voluntarily open this DCFS case against all things that are fighting inside of them. And I know when I'm feeling better, I'm doing well, this is what I can do to be better for my family. So it's part of that negotiation of what are their wants and needs, and really the underlying trauma that led them to that this is their coping strategy. This is their, I am trying to survive my complex rape trauma, and knowing that my birthing process might have been just as similarly traumatic, and I'm still having to be a single parent to these people, little people. So, right? We'll figure those out. So yes, it's really hard. But I've also found when they might not always have their born into or families of origin, but women survive well with creative families. Women survive well with communities that they can develop. So that was one of the projects I was working on with them, is they were all in a recovery home, and knowing that when one had an urge, her sister held her accountable. And okay, cool. I know that these are feelings. Hey, can we talk to Angela? Have you gone on a walk? Let's go to the grocery store. Let's do normal things. Let's take a break. Okay, there's 6 of us in this house. This mom will take care of our kids, and we're gonna go on a walk. Do you need time to have showers so the fingers aren't under the door? Like, what are these small things that are just that break? So it was really hard, but there were some. And one of the resources I used to use is
Thanks. Charles, can you talk a little bit about the recovery needs for men, especially men, transgender folks, and the sort of whether there's a match out there in the service network, particularly those who are at risk for HIV?
Yeah, I can do that, I think. But I want to start with just a little story, just a brief one. 15 years ago, I went to the podium in rooms like this on more than one occasion, which I mentioned and other communities, just like this. And I complained and I chastised to our policymakers. I complained to them that at that time, the funding stream was shifting. Funds were being taken away from programs that would tend to treat the clientele that I deal with, Black and MSM, who were at that time predominantly used with crack cocaine, and shifted instead to other parts of town, West Hollywood and other parts of town, to another demographic, largely whites, and Latinos, who were methamphetamine users. And if you look at the numbers 15 years ago, there was justification on some level for what I was concerned about. I can now today say that I was wrong, in part, that Black MSM have also been devastated by the epidemic of methamphetamine. So I know that there's a great need to design programs that are tailored for that specific population. We've made some headway in that area, but there are still lots of places where we can do better. Even on a simple level, like there are still residential treatment programs in LA County that designate one of the treatment counselors to be the HIV counselor. All the clients know it, all the staff know it, and the reason for that is you have one person who can specialize in service referrals for the clientele who might be infected by HIV or regular operation. The problem is all the clients and all the staff know that, and there's still a tremendous level of stigma in our community as well as in others. And so if I am enrolled, if I'm linked to that counselor, everyone automatically knows that Charles has HIV. And it's just, we haven't thought of a way around that. One way to me would be to train all of the counselors and being specialists in HIV because of the high prevalence of the HIV and the African American community. There's no reason why all of the counselors shouldn't be referred to as HIV specialists. We also know that while the numbers of Black MSM who are using methamphetamine has increased astronomically in a relatively short period of time, the number of programs that specialize in the treatment of those dealing with that challenge has not kept pace. In South LA, there are very few programs that have dedicated funding for crystal meth. And so we're still trying to catch up with that. But so there are lots of ways in which we are beginning to acknowledge the its impact on this demographic, but we're still far behind where we should be.
Great, Mike. So one of the questions I would have for you is, because you've been in this for a long time, and you're at an agency that is dedicated to providing these services. So can you talk a little bit about the generational shift you've seen as youngers come in to take the places of people who are aging up? Whether you see changes in what the presentation of meth use is like among those at risk of living with HIV, and sort of what services that we need to be thinking about that aren't there currently.
It's been really interesting. I sort of liked your comment this morning in regards to Cathy Reback's research and how it's still relevant, right? And I often get calls from the media saying, can you talk about the resurgence of crystal meth? And I said, what research? And it never went away. Amphetamines is our #1 drug at the Los Angeles Gay and Lesbian Center, the Los Angeles LGBT Center. And the dynamic of it is still pretty much the same. You know, it's a highly addictive substance that lowers inhibitions, that enhances the sexual experience, and it starts with the release of dopamine for the gay individual is really powerful. You know, dopamine's involved with our reward system. It allows us to feel our lives have meaning and purpose. It allows us to socially interact with each other and so on. And those are all very strong issues that gay men struggle with, right? So my experience with meth is that it blurs the lines, and so the drug becomes the common denominator. In our youth services, we do a lot of work with homeless youth, and they're using the drug for a very different reason. It allows them to stay awake at night. They feel safer on the streets. It staves up feelings of hunger and thirst. So if you don't have money for food, then that's a great way to not feel hungry. And more importantly, it allows them in what we call survival sex, which is prostitution in order to make a few bucks to get a room or some food or so on, right? And again, the HIV risk greatly increases as a result of that. You know, condoms are not a part of the picture. You know, it's really interesting that in prep of coming here today, I went to our IOP and I just talked to the guys for an hour and tell me what's going on, you know, and I was like, tell me about the conversations, and they're like, what conversation? We're not having conversations, you know. I assume it's the other person's responsibility to ask me, or my viral load is undetectable, so I don't have a fear of transmitting it. If the individual's on PrEP, then again, it's really interesting because I initially said, the combinations have decreased, and one of our social workers says, you mean the little conversations we were having to begin with, right? And so I think that's been the biggest shift that we've seen in regards to crystal meth and HIV, is that people just aren't having those conversations anymore, you know. So I think we need to bring HIV to the forefront again and really talk about it. And really, I mean, you know, things are so much better than they have been, you know, in the 80s and early 90s and so on. But that doesn't mean that there's not still a lot of stigma around it, you know. I may be getting off topic a little bit, but I find HIV and addiction have similar dynamics as it relates to the stigma, that it's more of a moral issue as opposed to a disease concept.
So I'm going to follow up with this question. So like I've had many clients, as I'm sure you have, who get a few weeks into sobriety and then want to get laid again, right? And so the general way that the generational difference today than when we were younger is that now you can get laid, just get onto your phone and
get on Grindr, yeah.
Right?
Yeah.
And you know, I don't know about you, but people I talk about the guys who say they don't use crystal show up with a baggie at the door.
Yeah, that's absolutely true, right? You know, even if they say on their profile, I don't party, they party. You know, it's hard to know where you're going and who you're going with, right? as it relates to crystal meth and early sobriety, as you know, meth releases dopamine 1,200 times more than the normal level. Cocaine releases 500, sex is 200, and then food is 50, right? To quote your stats. So, it's interesting, but what the brain's not really wired to experience that much pleasure, and whatever activity you engage in while high in them creates an imprint on the brain, and the two things get woven together like a fabric, right? So, particularly in early recovery, if I'm horny, I get triggered to use meth, right? And if I'm using meth, I have sex, right? And so, I believe there needs to be a period of abstinence from the last time that you had sex on meth to the first time you have sober sex. And that's really tricky, because how do you say that to a gay man who identifies with their sexuality? So that often becomes a challenge as it relates to that. So.
Yeah, I think that from my perspective, that's a place where we could be doing some inquiry and some work.
Right. Yeah, I just try to normalize it as much as possible, right? And I'll say to my clients, by the way, your first time you're going to have sex sober, it's going to be really awkward, it's uncomfortable, it's not going to be very pleasurable, but just if you're going to do it, get through it, And it's like I often say this, sex on meth is like hanging out at the playground and then going to Magic Mountain, right? Once you go to Magic Mountain, the playground ain't cutting it anymore.
That's a good analogy.
You can see it.
Charles, and the rest of the committee as well, one of the things that we also have been talking about this morning is jail. And the way in which jail is a disorienting experience. You take a person from the street who might have health care, who might be involved in recovery, but they lapse or relapse. They end up in jail. A lot of things happen, including sex. And then they come out. And it's very disorienting. Can you talk a little bit about what we need? I've done some work with Mario's people and with Billy Cunningham and Nina Harawa around the issue of the transition in and out of jail. Can you talk a little bit about what we need to, as a community, start thinking about building in place to make that transition less abrupt and to be able to provide continuity of HIV care prevention?
Well, I'm working on that project that you alluded to. So the key, I think, is having a smooth transition for the participant from the incarceration or the in-jail environment to post-incarceration. What our goal in this study is to link those individuals with a peer mentor who can help them access transitional services. We'll be providing them with what we're calling a passport, which is a mobile phone-based app that allows them to see where their appointments are for different services, to get incentivized for attending those service appointments. It gives them reminders about it. There's a geo-passport locator there that can actually automatically indicate to the providers where the client has access to service. So we're using 21st century technology finally to assist individuals in accessing services that they've been assessed for as indicating the need. And that's nice. What's missing there, though, is the human element. And so the second part of the project involves people. Linking the client with someone who's been where they've been. It's almost like using the 12-step model, where a sponsor is linked with a sponsee. The sponsor is someone who has experienced what the sponsee is just now beginning to experience. We've seen in other projects that I've been involved with the power of that dynamic, particularly in very hard to reach populations, such as Black and Hispanic. We also know that HIV and substance use don't occur in a vacuum. that there are lots of components to the individual who we're working with that need to be addressed, including spirituality, the need for social interaction and engagement. You really have to take a holistic and sort of global approach to designing care and treatment for the clients that are entering programs like ours. And the program that you alluded to is hopefully going to show results by the end of the study of having better rates of engagement and retention than some of the earlier models that we've used. So I'll let it run.
I'm not sure how many are familiar with St. John's Welshon Family Center. We have various programs, including PRIME, which is targeting the HIV Hep C population, transgender health program, ARC, the Assisted Recovery Collaborative, RISE, which is our reentry population, homelessness, CAD for those with youth with autism, and SLAY, which is for the GBQ youth, male youth. And so, along with other programs. And what we're finding is that there's a lot of these programs need to work very integrated, be as destigmatizing as we can be. I mean, we have a lot of strength at St. John's, but we also have a lot of areas that need to grow. Where, for example, not all, like I think you mentioned, not all clinicians are comfortable working with people with addiction. Not all clinicians are comfortable working with men who have MSM. How do we expect that of everybody? Why not? I think it's us in these different positions of privilege to challenge that and how to encourage that as a benefit not only to ourselves as a professional, but as a community that we're all part of. So with all the growth that we've made, we still have so much to do.
Great. That's awesome. One of the things I like to challenge some of my peers about is to make sure that in the waiting areas you have art and references that are from the people that are coming in to see you. So if people have, not like you want to have crack pipes on the table. The idea that, if you've got a predominantly gay culture group that's coming in, make sure that the arts and references are gay. You're working with people from underrepresented minorities, make sure that people, when they walk in the door, see people who look like them. This is little stuff that we can do. I mean, it also helps the employment base by bringing people into positions of power that may have been excluded prior. So there's a lot of work, and you're absolutely right. There's a lot of work we have to do. Even our beautiful UCLA health system, one of the worst things you can be is an addict and walk through the door. It's just not a nice thing. And the lady at the front desk, no matter who she is going to have a problem even. So this whole issue of destigmatizing is something that we really need to get serious about, because it's both, we always. Never mind. Go ahead.
It was really interesting. A couple of years ago, we started a medically assisted treatment program in the center. And as we were presenting this to the staff, there was a comment that was made, was like, oh, are we going to be treating those people, right? And it really raised a real red flag for us. And even, from the beginning of our managers, we trained the entire staff. We did a whole cultural competency on addiction and what medically assisted treatment was and so on. And I think, not only is it important to have signage in the lobby, and those kind of things, but it's really important to work with your staff. And it's not your client's responsibility to educate the staff, as you should know before they come in. So.
That's right, absolutely. I mean, our group just Thursday completed the training on implicit bias, and it was really tough. But we spent the money to have our staff go through this training, and it was really remarkable. And I can't underscore it enough. I mean, finding where your weak spots are and building them up, that's exactly what we as treatment providers and systems have to do. Other thoughts. I want to give each of you time to respond free form. And if you have some thoughts that you want to talk about, we're talking about meth and HIV in Howard County. Give us your thoughts.
You mentioned, we've been talking about fentanyl throughout the, And that story you told this morning, you runs through 3 gentlemen, one of them was a Senate employee. And it was really quite devastating to the center to lose this person because this person was not an addict, it was a casual user. And, fentanyl is 100 times more powerful than heroin. And it's really important for me to make the point that people tend to use the drugs that they do because they like them, right? People that use meth like to be stimulated, right? Fentanyl's on the opposite end of that, right? So and let's just talk about the casual user, right? If I'm about to party with some cocaine or meth, right, the last thing I'm going to expect is that there's going to be an opiate in there. So even if I'm not going to have Narcan on, I'm not, right? And I don't know if you know this, but the intervention rate for a heroin overdose is 1 to 3 hours. The intervention rate for a fentanyl overdose can be 45 seconds, right? So there is no way to intervene if someone goes in on fentanyl, right? It really becomes a part of prevention. And so the center has developed, back last year, we purchased 9,000 fentanyl test strips. We gave them all out. And then in January, we purchased another 20,000 fentanyl test strips. And we are aggressively distributing and doing outreach through all of Pride, all the way through Folsom Street. If you know what Folsom Street is, it's an event up in San Francisco. It's part of Ekow. But it's really important that people have the tools that they need if they're going to use, because basically we can shake our finger and blame, shame, or we can say, we know you're going to do this, let's teach you to do it safer, and so if you can provide them with the tools, chances are they'll make healthier choices if they know. I love what Cathy said in regards to the false positive. Yeah, those are okay. Yeah, we're great. Yeah, I'd rather someone not use because they got a false positive than doubt that it's accurate. So that's one of the biggest things that it's really for us. It's taken the opiate issue into a totally different direction. I guess I just really wanted to bring that up and really talk about it. And really, it's a bigger problem on the East Coast than it is on the West Coast, and we're just seeing it rapidly increase. And so, if anybody wants strips, they don't have them, they can come to the center, and we'll be more happy to provide you with some. That's what we're there for.
I like that I'm writing here too. One thing I just want to add about St. John's, I know there was some comment mentioned about the undocumented or underinsured folks. 55% of our population at St. John's patient care are people of no insurance or underinsured. So, people might be familiar with My Health LA. There's some where you can get primary care, but a lot of the specialty care not covered. But we'll still do it because we don't believe in closing the risk that. It's hard to catch everybody and identify everybody and give them comprehensive enough care. One of the things that I've seen very often in addiction, in trauma, is the complex needs for basic psychosocial supports, being part of something, being part of a community, being welcomed and not having that stigma, working with many people of transgender experience. They're more likely to be successful in their own recovery, in their wellness, in their participation, if their basic needs are met. How can we do that in our respective settings, in our approach to the working with the communities, in destigmatizing the language? And that's part of how we're trying to figure that out. Even if we have services for undocumented or underinsured folks, there's just never enough, right? For the complex needs of the communities. So I guess it's more challenging the state and the county to look at it backwards. Not what can we on the ground do, but how can we make this easier for us to do this?
I agree 100% with you. With the research, we'll continue to do our research and looking for ways of helping people that want to stop using or reduce using to be able to do that. That's a tough battle with meth because, as you know, there's really not enough that can help take care of much other than just stopping. And so we'll continue with that. I would like to be able to see more services available to the general population of being able to switch, once they're done with the research, being able to incorporate them back into other services. You don't sort of have that, and we can make referrals, but we're not really sure they'll get there. And if they get there, what kind of attitude they get, what kind of judgment they're going to get, and so chances are they're not going to get there. So we would like to be able to see more engaged to be able to do that, so that they can move on to the next step and get them covered.
Yeah, linkage is critical. The reality for the people that we serve is that there are multiple barriers that they have to overcome in order just to get into a treatment facility or a service facility. You know, they have to first acknowledge that they need the help, then they have to find where they can go to get the help, and then they need a phone in order to make the appointment so that they get the help. And then they need money for transportation so that they can get to the place where they get the help. And once they get there, they have to endure a 2-hour intake session. So there's a lot that has to happen in order to get someone from a place of pre-contemplation to active. And we need to be able to help them in ways that some of our funders don't smile upon. We need unrestricted funds so that we can provide incentives that will lure people in the door. If that's what it takes to get them there, then let's do it. We also need more traditional approaches to harm reduction / recovery. I'll give you an example. In South Los Angeles, there's only one place, one 12-step meeting that is specific for Black MSM, or where Black MSM are encouraged to attend. One, and it's hosted by Jeffrey King's organization in the meantime. Jeffrey. We also need non-traditional approaches. I saw some folks in the room earlier from the Los Angeles AIDS Coordinator's Office. They are one of our providing agencies that have funded edutainment activities where clients who are impacted are taken to a play that deals with homophobia, substance use disorders, and mental health disorders. They see the play, which in itself is exciting for them, and then they are engaged in a dialogue group for an hour and a half with a same-gender mental health clinician. That's then followed by a series of workshops with them to overcome trauma and stigma. So there are innovative as well as traditional approaches that we can take. It's happening, but it's so underground and on such a small level that many of you don't even know of any of the things that I've just mentioned here. So we need to be aware of the need and have the wherewithal to go ahead and expand these types of approaches.
With regard to access to services like what we do down at LA College, down at Project 90, I'm a peer mentor down there. One of my jobs is going to be to deal with all of the people and help them transition when they're coming out of jail. But one of the problems that we have that I have found is that we need to change the narrative from what we get in the media. The media's narrative generally and specifically tends to sway toward the negative. And what happens with that is most people on the average, the media is a powerful venue, and most people on the average would listen to the media, and sometimes things aren't things until the media says that they're things. So how do we change the narrative from on high to get people into not being afraid to come in for treatment, not being castigated for their illnesses or their problems, and having to come in to be able to get the treatment that is necessary? How do we change that media narrative from on high? Because if they're saying that, a lot of the time the epidemic isn't an epidemic until somebody that the media admires says that they have this illness and now it's an epidemic. So how do we change that narrative and get it down to where it should be and make sure that the people that need that help see that narrative and understand that they can come in and get the help that they need?
We do just what you did. We create our own narrative. We speak to the people who need to hear the correct message, hear the truth, and we talk to them. We engage with them one-on-one and in groups, large and small. And we keep doing it until they get it. Because the media eventually will catch up with the reality of what's true. But if no one's saying it, and we're afraid to, because we're obsessed with what the media, quote unquote, is saying, it'll never change. We'll never change that. So we just create our own and just do it.
Good morning. My name is Cynthia from the LA County LRP program, Linkage to Engagement program. And our clients are HIV positive and have some of them on meth. So how do HIV affect meth? How do meth affect HIV when we find our clients who are homeless and on the street, trying to get them back into care? So how do those two combinations work? Because most of the time they don't want to go back into care because they're on drugs. So do meth affect their medication, and what is the combination of that? How it works?
Yes. Yes. Long time ago when Dr. Shoptaw, when I was a fellow at Dr. Shoptaw. Long time ago when I was a fellow at Dr. Shoptaw, we did a paper on the adherence rates with individuals who are using methamphetamines, for example. There's a strong correlation with meth use and adherence. I think the issue when I'm working here as a clinical provider and HIV specialist is that we may have to get rid of that absolutism, right? That it's all or nothing. And I'm gonna have to work, I'm just thinking just for myself, when I'm going to change my clinical practice. And realizing, working with the client and the patient and realizing that I have to adjust based upon them, because my overall goal is their health care. Try to get that viral load down to undetectable. Try to make sure that hemoglobin A1C is under 7 as well too. And the little meth is in there. I have to realize that, and I have to talk to my. The problem is we're also facing problems with our payers. Our payers are creating guidelines, but we get dinged if we don't meet certain criteria, which affects our bottom line as well too. I think it's incumbent upon grantors like Mario over here and other individuals to realize that message as well too. If we're going to change as clinicians to realize that these patients where they are, the payers have to change this whole thing. And thanks for the show.
What other kind of ways of thinking outside of the box can we provide services for families? I remember back in the day we had Caring for Babies with AIDS, most of you probably don't remember. But we had patients who would do a voluntary drug treatment program because they knew their kids could go somewhere and be safe, and then they could get their kids back when they came out. That doesn't exist anymore. People are afraid, women are afraid to go into treatment, they're going to lose their house. They're going to lose their kids, lose their housing, when they come out, they can't pay their rent. And so they just don't know where to go. We need to start thinking creatively, not just women, but people who go into treatment, help them and what other kind of supports can we provide when they get out so that they haven't lost everything, like you were saying. Also, providers back in the day used to see people and meet them where they were at. Dr. Biondu is no longer with us. When I worked with her at THC Clinic, she would see anybody. And she would just, wake up, you know, I'm gonna see you, you need to be here. You're important to me. That doesn't happen anymore. People come in high, they don't want, they don't want to see you. You have to come back when you're clean or you're not drunk. It's just, we really need to think back, go back to the day when it was critical, when we were afraid because people were dying from HIV, and look at the fact that people are still dying. And we need to go back to that mindset where it was a crisis. We all worked together. We weren't trying to push each other off the ladder to make a name for ourselves. We weren't trying to hoard our patients because we were afraid we weren't going to get money. We worked together to do what was best for that patient. If we didn't, they were going to be gone before we had a chance to help them improve the quality of their life. And that's what we need to go back to.
I love that we talk out of the box because I think it's necessary. Just because we have a license doesn't mean you have to only practice in this way, right? And that's one of the things that I'm seeing a lot is that people are so scared to push their limits and trust their own competency as a member of this community, not just because you're a person in recovery or whatever. It's just, you want them to be well. Expect them to be well. Hold yourself to that standard. So I, as a supervisor, when I used to do FSP style therapy and everybody had access to the same intensive care options, you go out of the box, oh, you're in jail, hold on, I'll be right there. I'm gonna come by. Oh, your family abandoned you? Oh, and you're stuck on the street in the corner and you don't know where to go? Okay, this isn't necessarily therapy, so I had to figure out how to make this still fit within my scope of practice and know how to put it on a note, you know, and still be able to provide that comprehensive care that doesn't necessarily meet my boxes. Oh, I'm a clinical social worker, I'm a therapist today, and now I feel special. You know, it's how I expect of the teams I work with to push your comfort zone. And why? How do you hold that not just for to fit that box of like social work, but also just figuring out the resources, like planning out with the families. Like, oh, you really want to go to treatment? Okay, let's make calls. Session today is going to be making calls. Session 2 is going to be asking hypotheticals to these events. If somebody did this, what would happen and they wanted to get care? What would you recommend for them to do? Calling access and doing hypotheticals. It's honestly, I feel like the county's gotten more restrictive in how we can provide care. So we have to be more creative in how we can push our comfort zone. That's still like mutually beneficial and safe for everybody, right? Ultimately, those who are that's been primarily the youth and how we keep them safe while parents are also working on the So, and interestingly, there's a lot of more single fathers I'm seeing that can go into recovery home placements with their children.
Or even home.
Or shelters, homeless shelters. Yeah, and it's been interesting that how do we provide this care now? Is there a family out of state that would be willing to do this? Or while they're in addiction, I can't give you an answer, but I think that's where we create workspaces and figuring it out. And being comfortable with the uncomfortable.
Okay. Thank you again, Howard. I just want to say I'm a very privileged person to have been spending the last 30 years with community in this room. So I'm a very lucky man, and I'm smart enough to know it. So this is a red letter day for me, and I'll remember this for a long time. I am touched about the inclusion of elders in the room. We were here when people died a lot, and we remember this stuff. And it's really good to hear the voice of us at the end of the table being able to allow to speak up a few words and say, this is why we're here, is because of all of this. We need a set of action items. You know, one of the things that's different generationally today when we were working so hard is the intersectionalities of people and the ways in which funding streams demand silos. So we are a community that can demand change. Our patients are not going to be able to take to the streets and say, hell no, this won't work any longer. They can't. They'll be carted off to jail. So the idea that we as advocates have to get involved with our structures is one of the action items I want to see coming forward from here today, is that this energy doesn't just become a set of playing, ain't it awful, or if we could only do this, but we take it on ourselves to actually make some changes. We have good-hearted, kind people from the county and the city who are here to help us bring health They're looking for involvement. We need to be involved. Okay. With that, I'm going to turn it over to Ricky, and we'll start with Cheryl and Ricky talking with us about a call to action. And from the commission and from the city's Cohort office, look forward to hearing what you have in store for us to do next.
Thank you. So first of all, I want to thank the organizers, the presenters, and you, the audience. Without you, we'd just be talking to ourselves. So I'm glad you came. So we just heard a series of presentations and discussions as a baseline of what the issue here in Los Angeles is when it comes to meth. So what comes next? I think that we need to do a quick assessment. What am I doing? What are you doing to stem the increase of meth use in Los Angeles? What is my organization doing? If we have the programs, existing programs, how can we make those programs better? If we don't, how can we enhance these programs so that they include services for people who are using meth? What else can you do? I can tell you what I can commit to. I can commit to collaborating with anyone in this room who wants to have this conversation, who wants to continue this conversation. I can also commit some resources into the development of an action plan. And I can bring the political muscle of the city to the table as well. The last summit like this that we had was on opioids. As a result of that conversation, the mayor's office started an internal working group on opioids in Los Angeles. My intention is to take this topic and have it included in that conversation as well so that we can come up with something together. Meth has been an area of concern for Los Angeles for many, many decades. We all need to recommit to coming together and finding new ways of dealing with this issue. We can't continue to do the same things and expect a different outcome. We need new ideas, we need new allies, and we need to come together to do it. And I'm ready to do it. Are you guys?
So I just want to echo all the comments that I heard today, and I'm always so impressed with the amount of action items that came out of the discussion. Everybody's questions and concerns that were put out today were incredibly helpful. So we have a long action list on behalf of the commission. And I'd like to start by saying that there are several members in the audience actually that are specifically interested. We didn't plan this out. Members and co-chairs of the Commission's Public Policy Committee and Planning and Priority Setting and Allocation Committee. So likely the two committees to lead off the conversation in terms of what we need to do in terms of prioritizing services and allocation of resources to those communities that need. So I do think that one of the key takeaways on behalf of the Commission and for us to continue this dialogue is how do we engage all of you, how do we engage people that are not in this room in making bold decisions that would feel uncomfortable and incredibly painful. In order to make the greatest leap forward in terms of our HIV/AIDS strategy, we have to make some very difficult decisions in terms of where we shift our resources. And oftentimes those call for some very honest take on where we need to go as a community, not just one agency or just one community that represents a particular interest, but as a whole in Los Angeles County. So I believe that the commission, with the leadership of our co-chairs, as well as the members who are here today, are really interested and intentional in that conversation. So we look forward to facilitating that dialogue with you. I do want to take a moment that it was intentional with the planners and the people behind the scenes that the title of today's conversation is Methamphetamine and HIV, the Crisis Continues. And upon my personal reflection and my involvement with public health and the commission and in the county in general, I think it never really left us, right? It never really left us. Perhaps a little bit of acknowledgement that we might have fallen asleep at the wheel, or we got distracted, or we forgot about other priorities, is probably in order, not to say to place blame on our community or to place blame on ourselves and or the system or the failure, but to really think about the grappling with the challenges that we face every day. when there are multiple pressures to act upon healthcare, when there are multiple pressures about the political environment, when there are multiple pressures about the lack of resources, we're forced to shift and move at the same time at multiple points and multiple times in our lives and our services. So I think this is a great pause. This is a great pause for all of us to go back to our communities, to go back to our bosses, to go back to our friends, to go back to our families, and think about sounding the alarm again, to ring the bell again, that this never left our communities, it never left HIV. And in fact, we need to be woke again in a way that we have never been before. So the challenge starts today. We are going to use the attendees from the commission to bring this back to our group. But I hope that moving forward and leading today marks the beginning of a long and important dialogue to move forward. So with that, let's get to work. Thank you.